Sally, are you able to unmute yourself? Okay, good.
Hello, everyone. My name is Salih Abbas. It's my pleasure to welcome you all to our webinar covering the impact of COVID-19 on urban settlements in Kenya. The meeting will start momentarily. In the meantime, I will just share a few housekeeping rules and I'll repeat those as we get started. All participants in this webinar will be muted to avoid unnecessary disturbances. We ask that you feel free to share your questions and interactions in the chat box. We will have somebody monitoring your submissions and they will be submitted at the end for our Q&A session. Lastly, we want to inform you that this webinar is being recorded and will be shared on Population Council media streams in the future. Thank you for your patience. We'll be starting momentarily. Hello, everyone. My name is Saleh Abbas, and I'm an intern with the Humanitarian Task Force, and it is my pleasure to welcome you all to our webinar covering the impact of COVID-19 on settlements in Kenya. I will now share a few housekeeping rules for the webinar. As you notice, all participants in this webinar will be muted to avoid any unnecessary disturbances. We ask that you feel free to share your questions and interactions in the chat box, and please make sure you specify who these questions are for. These questions will be that are submitted for our Q&A sessions at the end. Lastly, we want to inform you that this webinar is being recorded and will be shared on Population Council media streams in the future. I will now turn this over to Dr. Twine No, Global Director of the Poverty, Gender, and Youth Program and the founding director of the Girl Innovation Research and Learning Center at the Population Council. He will be our moderator for this event. Twine, over to you.
Thank you, Saleh. Good morning, good afternoon, and good evening, everybody. Thank you so much for joining the Population Council and our partners at this webinar. It is my great honor to welcome our panelists from the Office of the President in Kenya, the Ministry of Health in Kenya, Amref Kenya, as well our Population Council colleagues in Kenya as well, and welcome all participants. So why are we focusing on COVID-19 in informal settlement today? Many of you might know 1 in 8 people around the world live in urban slum. I will use the term urban slum and informal settlements interchangeably today. That's adding up to about 1 billion people globally living in informal settlements. 60% of the urban population in Africa live in informal settlements. And by 2050, about 70% of the world population will reside in urban setting. So if we don't address the inequity and the health disparity in urban and informal settlement, you can see that this issue will exacerbate. And many of us know the population who are migrants and urban poor are often neglected and marginalized in access to health and social services in urban slum. And overcrowding, inadequate housing, and lack of access to sanitation and water can exacerbate health conditions, both communicable diseases like dengue or COVID-19, or non-communicable diseases like mental health, obesity, and poor air and air pollution. And we have known that the COVID-19 pandemic have compounded and further exposed the disproportionate health risks faced by the urban poor. So we have been tracking both the direct and the indirect impact of COVID-19 on this population. It's my great pleasure to moderate this event because I've been working with our colleagues in Population Kenya on producing timely and relevant data for policymakers as well as practitioner on the ground to help curb the pandemic. And why Kenya? I think one of the great lessons that throughout the pandemic that I have learned from our Kenyan colleagues is that they have been quite good at mobilizing both practitioners, but as well as researchers together with policymakers to formulate decision around how to handle the pandemic. So we'll be hearing from them on how they are doing that today. But also we really want to use this opportunity to kind of bring forth some of the evidence on the impact of COVID-19 on this population and really learn from our panelists on how they go about in addressing some of this issue, but how do they work together? I think as somebody who's based in the United States, often the response to the pandemic lack data and evidence. So I'm really interested in how is Kenya doing it with this unique group of panelists who represent this different angle of the public health response effort. So, but we also going to talk to them about what next and what are they expecting as the pandemic shift shape. So hopefully they'll be able to bring us to draw some lesson learned that many of us can take to our work as the pandemic continues. I'd like to now introduce our panelists. Next slide, please. Oh, okay. I will just introduce our panelists before we go into our presentation. So first, I'd like to welcome Ms. Julie Amwabe. She's the gender advisor, and she's worked with the policy and strategy unit in the executive office of the President of Kenya. And we have the pleasure of being working on some adolescent research with Julie throughout the pandemic. So it's great to have her perspective here and have that national framework on how she has worked closely with the Office of the President to bring forth some of this issue. And also we have Dr. Maureen Kimani joining us from the Ministry of Health of Kenya. She's the head of the Division of the Community Health at the Ministry of Health. And she is the team lead for COVID-19 community engagement, who's also a member of the COVID-19 task force. And we also have Mr. Joe Oele. He's from Amref Africa in Kenya, and he has been a strong champion and advocate for the recognition of community health workers, who, as we all know, is the frontline workers throughout the pandemic and in normal time as well. And we also have Dr. Tim Abuya, who's an associate at the Population Council Kenya. And he's Dr. Abuya has been focusing on reproductive health research in Kenya. He's based in Nairobi. And last but not least, we have my colleague, Dr. Karen Austrian, who's a senior associate at the Population Council Kenya, based in Nairobi. And she's have been doing adolescent empowerment research throughout her career, but have been really spearheading a lot of the COVID-19 research. So I like to go through the agenda a little bit today. So we will first begin with true to form. We want to begin with a presentation on data and evidence from Dr. Tim Abuya on the impact of COVID-19 on informal settlements. And then we will go to our panelists to kind of share with you what they've been doing and how do they use data and evidence to inform their response effort. And then I will move on to a more fluid discussion with the panelists. And that's when I welcome questions from the audience. We'll try to be as interactive as we can to take your question and present them to the panelists. And it's not just me talking on the panelists talking, but it's allowed them to engage with you a little bit. So please chat your question and we will monitor them and we will use them throughout the panel discussion and the Q&A session. But without further ado, Tim, over to you. Thank you very much. Welcome, everyone. Welcome, Tim.
Thank you very much, Troy, and thanks everyone for joining this webinar. I would like to welcome you this evening from Kenya. Good morning, wherever you are. This afternoon, this morning, from wherever you are, I'm going to present some data that we generated over time and give it a slant towards inequities that informal settlements often experience. So next slide, please. So just to give you we started in mid-March 2020. We approached the Community Engagement Committee on what can we do to be able to advance, provide evidence that is useful for guidance towards response. Our early goal was basically to collect knowledge, attitude, and practice data in the urban informal settlements in Nairobi to inform the National Emergency Response Committee and the Ministry of Health towards messaging and responses towards COVID-19. As time went by, we looked at the social health and economic impact, as well as we were able to make some recommendations on possible responses as the pandemic. We looked at gender differentials, as well as some examples that I'll give in the policy relevant data as the pandemic evolved and responding need shifts. We needed to remain open and flexible to adapt to the changing dynamics. We worked with the Ministry of Health and with the Executive Office of the President and Population Council Kenya office to be able to generate this evidence over time. Our CAP data in the informal settlements focused largely initially on what do people know about the symptoms, the infection and prevention, stigma, and later on home-based care. The social and economic effects of the pandemic, we focused on income loss, food security issues, access to healthcare services, mental health, violence, and the gender effects. We also incorporated later on impacts on adolescents. Next slide, please. So we conducted 4 rounds of phone survey, monthly data collection between March and June. Nairobi, they included Huruma, Kariobangi, Mathare, and Dandora. The council had a long studies going on in the informal settlement, as well as a number of qualified research assistants whom we mobilized quickly to be able to support us generate this evidence. We looked at settings that are informal in nature, quite crowded, mostly involved in daily labor in the informal sector with poor water and sanitation infrastructure. We discussed with government partners what key data was needed. We developed the survey tool and shared our survey tools for input to the Ministry of Health and the Presidential Advisory team. And we shared early learnings and of the preliminary findings to get input from partners for recommendations and framing. And we presented these findings on a weekly basis or wherever it was available on the virtual meetings that the Community Engagement Committee used to have. And we still have some of these meetings today. We then shared widely these results into informal policy briefs and PowerPoint presentations with a range of stakeholders. Overall, we sampled about 2,000 households from the ongoing cohorts. 37% of these respondents were male, 63% of them were female, with an average age of 36 years. In round 4, meaning later on in June, we conducted adolescent interviews across the several settings beyond Nairobi. Next slide, please. So I'll probably now move you towards the data and just have a feel of some of the dimensions of data we generated. We looked at, for example, in the 4th round in June, we looked at what are the attitudes and what is the possibility of implementing home-based care. And I took this slide particularly to uncover the role of women in supporting home-based care. It confirms that home-based care in the informal settlements is not quite feasible. It's quite challenging. For example, 10% of our respondents reported that they have a place in the house to isolate if they needed to do that for a patient. As you can see here are the examples of stigmatization was reported to be quite high if they had a COVID patient inside the house, and women would care for such patients, meaning it would be a double burden for them if they were to care for patients and at the same time be able to do other household chores as expected in this context. And about 68% of them said they were willing to care for a patient, but unfortunately the context was quite complex. And out of these results, a group of stakeholders within the urban setting came together and says, within the context of the current guidelines for home-based care, do we need alternative ways in which we could implement strategies to support home-based care? And that discussion generated some form of alternative thinking around ways to implement home-based care. Next slide, please. In terms of food security, there seems to be a crisis, or which was incredibly high over time, as you can see on this slide, between April and June. And we have disaggregated this data by gender. And as you can see, overall, we see that women reporting skipping meals or eating less in the past 2 weeks due to COVID-19. 6 out of 10 reported their biggest need in this population was that was need addressed is food, and 3 out of 10 say is cash. And actually, you can see 17% in June, for example, reported skipping meals every day, while 69% skip meals several times per week. So the trend, as you can see here, is that over time, the rate of food security was extremely high in this urban settlement. Over, next slide. In terms of domestic work, again, this is basically looking at other disparities, other inequities, other challenges between gender. And we see no real change between May and June when we looked at the question of, compared to before COVID-19 in the past 2 weeks, have you spent more time either cooking, cleaning, or more childcare? And we see the burden being greater among women compared to the men. And as I mentioned earlier on, if they are to have this burden of household chores in addition to care for a patient in the household, that would really disenfranchise women in this particular context. Next slide, please. So in general, if you look at gender considerations, women were impacted more on many aspects of their health, social, and economic dimensions compared to men. Actually, they were more likely to skip a meal due to COVID, or forgo healthcare services, or increase household tension, report increased household tension, or violence, or physical abuse by partner and sexual abuse by partner. So we see that in the context of the data over time, we saw that women were negatively impacted by the COVID situation. And this evidence was important so that the gender dimension in implementation of strategies to alleviate the challenges of COVID-19 required a gender lens. And this recommendation was provided to the ministry and the National Emergency Committee over time. Next slide, please. Now, I'll just take you through on the dollars and data so that we can have more time for discussion. And as you can see, we looked at the effects of COVID-19 on education. While over 95% reported doing learning while schools were closed, the methods were mixed. As you can see on your extreme right, the others were reading from other books, 57%, 43% were given materials by the school, and mobile phone in about a third of them. And when they were asked, we looked at if they were able to go back to school if schools were open, and 86% of girls and 80% of boys were attending school pre-COVID. And when they were asked if they'll go back to school when they reopen, there were slight differences between girls, with more boys saying they're likely to go back to school compared to girls. And the main reason for not returning to schools were fees or fear of overcrowding in the school setup, which basically gives you a dimension of the possible inequities around access to education during the pandemic and even when the schools reopen. We also saw a digital gender divide, with boys more likely to use computers and tablets. Less than 1 in 10 respondents aged 10 to 14 years, and the less than 4 in 10 respondents aged 15 years to 19 own their own phone, which means basically access to digital space was also a challenge within this particular setting. Next slide. If you look at effect of COVID-19 in terms of their social effect and emotional effect, we see we do not see quite an increase in COVID-related pregnancies. We had a reporting of about 0.5% of girls who say they got pregnant over this period. Perhaps teenage pregnancy was a problem, obviously pre-COVID. However, the environment may have exacerbated this the risk of pregnancy. And as I'm going to say later on, some of the things we're going to do later on is to track this and over time to see what happens later on early next year. But as we also reported about 2.5% transactional sex incidents, all more than before COVID-19. We know that the risk factors for early pregnancy, marriage are present in the context of COVID-19 pandemic, like school closures, economic stress, transactional sex, or low use of contraceptive. And as you can see here, for example, 74% of them reported spending less time with their romantic partner, and 50% felt depressed or hopeless in the past 7 days among the adolescent, which means some of these social stressors are likely to exacerbate the environment for other risks, including pregnancy and STIs and HIV-related conditions. Over. Next slide. So in general, we then generated some of the recommendations. Each cycle of data, we had specific recommendations that spoke to the data. But we largely, most of our recommendations focus on public education, the need for individual responsibilities, the need for addressing stigma, what to do if one has symptoms, and the need for implementing social protection mechanisms to address the food crisis, the cost of health services. And among adolescents, we discussed, we generated recommendations about the need to subsidize fees for students, because one of the reasons why about 60% of our adolescents say they couldn't go back to school because they could not afford fees, and it's because of the economic effects of their parents couldn't afford, cannot afford because obviously they are not able to have enough income. As schools reopen, we also recommended that need to take into account the various experience of learning at home during the closures, and we are happy to say that, for example, when the grade 4 and class 8 and form 4 reopened a week ago, they had, about 2 weeks ago, they had of the status of the students across the country for those who are able to do that. And we also recommend to strengthen existing programming for adolescents to address the mental health and violence against children and other sexual reproductive health challenges that they are facing. Next steps then, basically we are hoping to explore additional relationships, next slide, between adults and adolescents and the short-term impacts on COVID-19. And we're going to look at long-term effects on livelihood, school dropouts, pregnancy, and child marriage in the subsequent data collection activities. And we're going to report on the roadmap for adolescent girls investment in the COVID-19 recovery period. And we are going to collect some of the data we've collected in the past is quantitative. We are also going to include some qualitative data with adolescents to examine their experiences and some of impacts and effects of COVID-19 on their lifestyle. So I'm going to stop there and perhaps over to you. Next slide, please. Over to you, Twai, to be able to go to the next session. And I'm happy to pick up questions and suggestions in the chat box. If you're able to do that, I'm happy to pick them up. Thank you. And over to you, Twai.
Thank you very much, Tim. That's great. It's just so impressive to see all the data you have, not just on the individual, but on the household level. And it's really captured this multitude impact that the pandemic has on this population. We'll dive into the presentation more, but so feel free if you have questions for Tim, please chat them. But I'd like to move to our panelists. Epidemics are localized, so our expertise and the response effort. So you are in for a treat to hear from a wide-ranging group of experts here. And I would like to begin with George, just to hear your perspective on the front line working with community health workers, and how do you kind of handle the pandemic thus far, and what do you expect next? So some reflection from you, George. George, please mute yourself if you're speaking.
Thank you, Thai. Good afternoon, once again, the audience. As I said, I'm Joe Joel. I work for Amref Health Africa in Kenya. Yes, as Dr. Buya has presented the findings of that study, it is reflecting the true scenario of the impact of COVID-19 on the informal settlements in the country, Kenya. And I would want to agree with him that when this occurred, when the COVID-19 pandemic was announced in March, the government came together and put strategies in place in partnership with private sector and NGOs. And Amref was not left behind. We had been in the forefront partnership, having been working with communities for over 60 years. And so in the area of study, that is informal settlements in Nairobi, we have seen our engagement with the national level policies and also with communities and partners to put in place strategies that would help in reducing the impact of COVID as it is reflected in that study. Therefore, we have worked through a partnership, public-private partnership approach to come up with the policies that would facilitate the implementation approaches on COVID-19 containment. As Amref, we have also moved out and engaged our traditional donors and other donors in resource mobilization that would help in terms of addressing the impact of COVID in the informal settlements and all beyond the informal settlements, yes, not only informal, but for purposes of this particular theme of the day, we have worked very well with communities in those informal settlements in Nairobi and engaged in resource mobilization, both kind and in kind. We have also engaged in ensuring that community participation and sensitization is given a priority using the community volunteers, community health workers, and other stakeholders in the community that could be mobilized to step in the matatu industry in the informal settlements, the people who have dropped out of their regular informal activities or engagements of jobs, and now they are there. So we have worked with them and mobilized the communities, and community health workers have been highly supported through capacity building, so that when they go to the households to sensitize and identify people who might have been presenting with symptoms of COVID, then they know what to do. They could do effective referral and engagement with response teams on the ground. So we have done that, and we continue to engage, even at the moment when we are seeing the spiking coming up. Amref has not rested. We have continued to engage a strong partnership with other partners and the government on this approach. Over to you.
Thank you very much, George. Thank you for all the important work that Amref and yourself are doing. And yes, Amref have not rested and will continue to maneuver the pandemic. Now, I'd like to invite Karen for some reflection. Karen, Austrian, and I have worked together closely, but she's in Kenya and she's been kind of spearheading some of the research there. So I'd love to kind of bring her in and have some reflection on her process of research and how that has been translated into the response effort.
Thanks, Twy. Yeah, so just a few thoughts and reflections. listening to Tim and George and just thinking about the importance of data and evidence and how that is really critical in tackling inequities as we think about COVID responses. And one thing is, I think that what's been really sort of important in Kenya is having local data. I think while this is a global pandemic, I think it looks different in different countries. And so being able to really use data from that is being collected in real time in Kenya and being able to share that with policymakers and with program implementers to help them sort of use evidence as they're very quickly making decisions about response and community programs has been critical. I think when the pandemic started, there was a lot of sort of theory work coming out about this is what we think is going to happen to women, to girls. This is what is likely to see in terms of teenage pregnancy or early marriage or things like that. But it was, not out of thin air, but really sort of theory and hypothesis based. And I think the work that we're doing to collect actual data on these critical issues in the time of COVID to really ensure that the responses are evidence-based. For example, within the first couple of months of the pandemic, within April, May, there was a lot being reported in the media or on social media about spikes in teenage pregnancy. And I saw a question on the chat about that. And so we were being asked by policymakers, is that true? Is this really happening? And from our data, what we were seeing is that that it's not. As of May, June, there was not a spike in teenage pregnancy. And that also, our other colleagues at AFIDEP did an analysis of the health system MIS data and saying that that's also not true, but it makes sense because from what we know, adolescent girls typically don't present for prenatal care until they're well into their second trimester, early third trimester, so it's too soon. What we do know, and what Tim alluded to in the presentation, is that all of the risk factors that increase the risk of teenage pregnancy, whether it be being out of school, economic stress in the household, lack of access to contraceptives, are all there. And that's why I think the ongoing nature of our data collection and the longitudinal nature of the data collection is important. So as time goes on, we will be able to pick up spikes, but I think that really is a longer term outcome. I think that also just being very grateful that we were able to leverage ongoing work. So these are ongoing cohorts that we had that we were able to quickly flip into and sample from so that we could make them useful for the COVID-19 response, as well as just our human resource capacity in terms of from our investigators to study coordinators to data collectors to really be able to put that to use within a matter of days, frankly. And finally, just thinking about sort of the approach that we had been taking to our research prior to COVID-19 in terms of thinking about what are vulnerable subsegments in society and not just taking it for granted that sort of a national statistic or even a Nairobi-wide statistic, but we know that there are always pockets of vulnerability, informal settlements being one of them, but even within informal settlements, thinking about how are men and women being affected differently. And I think also our multi-sectoral approach of not just taking only a health lens, but knowing that the economic situation and fluctuations in economic situations affect health outcomes. And we saw that very clearly in our data that the main reason why people said they were skipping health services was because they couldn't afford them. And so we see very clearly links between economic impacts and health impacts. And then I think that led us, as my last reflection, to really going back to, and maybe it's my own personal bias as being an adolescent researcher, but making sure that adolescents aren't left out of the data on sort of the effects of COVID-19, because adolescents are typically seen to be relatively healthy. They're not the ones that are becoming critically ill or at risk of critical illness with COVID-19, but the data that we collected from them show that they are being profoundly impacted, whether it be school closures, sort of turning their lives upside down, increases in domestic work that they're taking on, the toll on their mental health, on their nutritional status. And so really applying what we knew beforehand about how vulnerability manifests in different subsegments of the population and applying that to the way that we're thinking about COVID-19 and the types of recommendations that we're able to make to policymakers. So I'll stop there. Thanks. Back to you, Twai.
Thank you so much, Karen. Great reflection. We'll dive into some of that later, but I'd like to invite Dr. Maureen to come on. Dr. Maureen is on the COVID-19 task force in Kenya. So she's in the mix of it all. So I'd love to hear from your reflection from the data, but also the work that you've been doing throughout the pandemic. Over to you.
Good afternoon, good morning, everyone. Thank you, Tai, for this opportunity. So I just want to just briefly just give a background of where all this started. Of course, COVID was new to us, and I think for us in the ministry, we had started some work when WHO started telling countries about COVID. But the real work started around March when we got the first case of COVID-19 on March 13th. And that's when the National Task Force as a ministry was set up. And also those other multi-sector team that was put together, the National Emergency Response Committee, which was made up of different ministers from the different ministries, but I will focus myself on what we did within the health sector. So within the health sector, as I said, I lead community engagement. As you know, with every new pandemic and new things, as a ministry, we need to quickly and to be fast sensitize the population and make them aware about what. And of course, as we do that, a lot of this communication that was also being done. So what we did initially at those very early stages was to put together a risk communication and engagement strategy, which was a very fluid or very dynamic document, which kept on changing as we kept on learning new things during the pandemic. And then we realized that we couldn't do this alone as a ministry. And so what we did was to bring on board as many sectors as possible, but also work with the non-state actors, the NGOs, the research institutions, which probably traditionally we wouldn't be working so closely or rapidly translating research into action as we did. So the good thing is that POP Council is already a member of our technical working group as a division of community health. And they came on board together with many other partners, and everybody was putting on the table, I can do this, I can do this. There was a lot of enthusiasm to support the work that the ministry was doing, especially in terms of risk communication and community engagement. So we realized we needed to know what was the level of knowledge. Of course, this was new thing of infodemic out there. Lots of, nowadays we live in a social media world. Whatever is happening in China quickly comes down in seconds to people's phones. So it was important to ensure that we were giving the right information or creating awareness to our communities in a way that they could understand and they would not be so scared, because there was a lot of fear in the beginning. And so what we did was, of course, we didn't have a running research at that time, which could quickly inform some of the strategies that we were trying to put across. So what we did is that we leveraged on what was already going on at POP Council, since they already had a cohort, I think for HIV. So we leveraged on a HIV cohort, and quickly started doing these phone-based surveys. And I think without the work that Pop Council had been doing, we wouldn't have gotten all the information we got, because we were able to know what was the level of awareness in the communities, what media or what channels of communications were mainly delivering this COVID information to communities, and what could the communications people leverage on or do more at that point. And then also, where were the gaps? So we realized very early on, there were issues with knowledge. People didn't have the knowledge. Of course, so the practice was also low. But as we moved on, as we continued doing this, the 4 rounds of the service, we're able to understand different things and therefore also program differently, working together with the county government, because you know that in Kenya, health is devolved to 47 counties, and therefore we had to closely work with them to translate whatever information or whatever actions we wanted them to take quickly downwards. I think I also want to say, beyond what team presented here, we were also able to look at some of the challenges that communities are having. For example, our earlier messaging at that point in March, April, was we wanted people to stay at home as much as possible, not to go out unnecessarily and so forth. But then when we did, I think it was the second round of the survey, we realized now people didn't have food. I mean, you told them to stay at home, but then you didn't provide food to them. So then food becomes a more urgent issue for them compared to telling them to take care because of COVID. So we started working with the social protection sector, so that at least in the informal settlements, we had lots of our partners supporting vulnerable families with some food. But then we also had government itself supporting through what we call the Inua Jamii program, where families are given a certain amount of money every month, and they can be able to at least get for themselves some food and so forth. Then I think as we went on, we realized now people are staying more and more at home, and there were tensions at home because maybe the man could no longer bring in food to the table. And of course, that brought in some gender perspectives, which again, I think that COVID was not just a pandemic, but it was coming with many other things which very early on we hadn't critically thought about. And so a lot of programs or interventions were being started as we go along. So all this information, what we did was that every time Pop Council finished any survey, they would put together a brief, which we would share with the National COVID Task Force, and different subcommittees had been formed, which would take specific recommendations that concern them and probably start putting in some actions if we needed more capacity building. Lots and lots of webinars and virtual meetings were done with the counties and other healthcare workers, and just to bring them on board on some of the emerging issues so that they could become more sensitive, even as they managed the community down there. And I think the other thing we knew we rapidly had to do was to put together guidelines and some very rapid documents. Of course, you know, in ministries, there's usually a lot of bureaucracy before you can release any kind of guidance out to the population. But during the COVID time, that bureaucracy was very minimized, that you could actually get a document out within days out in the community to show them how do we want you to behave at home, in the residences, what IPC or infection prevention and control measures we want people to undertake during these COVID times, whether it's in the workplace, whether it's in the eatery, and so forth. So I'd want to say that there was lots of rapid documents, guidance that was rapidly being put together, all because of the information we were consuming from the research that we did. But in addition to that, maybe something that was not presented in these findings was that in addition to the work, the CAP surveys that we did, we also did some analysis of what were the myths and misconceptions that were out there in the community. And those, again, we really utilize the analyst skills at Pop Council to give us information week on week. So we knew our community health volunteers were going to households every other day and would ask, what are people talking about COVID? So there's all this information. The CAP service shows there's almost 100% awareness about COVID, but what are the running themes? What are the things people are talking about? Because that would inform, would they change their behavior or not? So we understood that there were some who felt COVID is a disease in China. It's a disease for people who fly, who do a lot of air travel, or it's a disease for the rich, for example, or for people in urban areas. And so that really also helped us to change the risk communication, because I remember very early on, a lot of the communication that was out there in mass media was probably, it was a poster, it showed people traveling. So travelers pulling their bags and near an aeroplane. So of course, the people who don't travel thought, well, I don't travel, so this can't get to me. But then we had to change that narrative when community transmission became a reality in the country. So it was no longer questions of, have you traveled? But it was a question of, are you having this kind of symptoms? And can you quickly, if you get to maybe you're starting to have this kind of breathing and so forth, or you came into contact with someone who had such kind of symptoms, you probably have COVID and you need to go for testing and maybe get into a quarantine or isolation facility. And I think a lot of this information also informed how we did our quarantine and isolation. So I think in summary, what I have seen during this COVID is that for a long time, research and policy always took such a long time, but surprisingly during this pandemic, we saw that research was able to quickly inform policy and implementation of what we are doing. I want to stop there. I think I've taken too much time over. Sorry.
Thank you so much, Dr. Marine. You have a lot of responsibility on your hands, so it's just really good for the audience to get an insight on how all this work behind the scenes. And often many of us do not have these sort of insight on the decision-making process and how the Ministry of Health use dynamic level of evidence to inform your work. So really appreciate and thank you for all your work. I want now to invite Julie Amwabe to kind of hear her reflection on working at the Policy and Strategy Unit within the Office of the President. Welcome, Julie.
Thank you, Ty. I like what Dr. Kimani has said, and she's really given an overview of what the Ministry of Health has been working on, the steps, the decisions they've had to make, and why. For the Policy and Strategy Unit, I think our core mandate is to provide technical and policy coherence, particularly around the President's Big Four agenda around food security, affordable housing, enhancing local manufacturing, and obviously the universal health coverage. This has really been big, particularly around this time of the COVID time. The government of Kenya and the President of Kenya particularly has emphasized importance on young people. He is the global champion for youth empowerment under the Generation Unlimited initiative. Kenya is also leading in the gender-based violence coalition under the Generation Equality initiative. We recently signed up to lead in the Global Partnership for Education to transform education systems for more than 1 million boys and girls globally. So young people have been very core at the center of President Uhuru Kenyatta's agenda. And I'd like to say, we've worked with Population Council. We came, obviously with COVID, looking at the impact of COVID on adolescents. And why adolescents is, we felt that when you look at adolescents and how the government structures work in Kenya, adolescents seem to be sort of falling through the cracks quite a bit. When you look at Ministry of Education, we probably deal with the, going back to school and if that's the right thing to do and when. Then you have the Ministry of Health. There's a lot about the reproductive health bill. Then there's the Ministry of Social Protection and Labor that focuses a lot on the violence studies that they've been doing. So the thing is, Kenya, we have a lot of policies and they're working and they're strong. And these policies and frameworks have contributed to significant improvements for many women and girls in Kenya. But the issue that we've been seeing a lot is a lot of these investments are not speaking to each other. So we end up dealing with adolescents as, we'd say the health or the education or FGM or child labor, but not necessarily looking at a girl in her totality. And so that's why this study was very important to us, because we are able to look at from her mental health, the economic impact, childbearing, and yes, teenage pregnancies as well. So there's a lot that we're looking at, and having data allows us to sort of be able to bring the key stakeholders and everybody around the table and sort of discuss whether what is really working and what is not really working. What interventions do we need to put forward? What policies do we need to enhance and push for and rally behind? And like Karen said earlier, a lot of the data coming out, or a lot of the studies coming out on the impact of COVID are projections or theories, but then I think it's just critical that we have good data and strong data to back up some of this interventions and a way forward. Over time.
Thank you very much, Julie. It's just great to hear how you work across ministry and across partner, and really nice to hear. I also focus on a lot of adolescent research and young people, so it's really nice to hear that Kenya at the highest office is prioritizing the needs of these people, and particularly during this time they are at home, and we heard it from Tim, they are experiencing mental health, but also there's learning difficulties, and particularly in the informal settlements, it's quite difficult. So Sally, could you move to the next slide? We're now gonna transition into a panel discussion, and I would wanna take this opportunity and take audience question as well. But perhaps I will open this up to all panelists to kind of reflect this question. One thing that I take away from all of your presentation is that this idea of you using readily available data, but being able to discern what's real and what's not real, but also the, I think we are operating in an information influx era. So how do you work together as a group of experts, from scientists to policymakers to practitioners, to kind of coordinate your response effort and to translate data into practice, into policy? As particularly in March and April, we did not know much about the pandemic, so or the disease itself, and now we're learning a lot more. So I think this would be a nice kind of lesson learned from the global health and development community to understand how Kenya is kind of use data and evidence. Certainly, there's many governments around the world who are not using data and evidence in their response effort, or they deprioritize data and evidence. So I'd love to hear from all of you, and perhaps I'll begin with Dr. Maureen, and other people, please feel free to chime in. Dr. Maureen, would you unmute yourself?
Go ahead, Dr. Maureen, I've unmuted you.
Oh. Okay. So thank you, Chai. I don't know why I managed. I'm meeting myself, but it's okay. So that for us as I think I'll talk on in regards to community. That is where I was doing a lot of coordination. So so in terms of how we were able to bring in all these partners, I want to say that one, I think one of the things I noticed is that we needed to have very strong and coordination, because we had different partners who had come on board who had different interests. They had different skill sets, and we all wanted to bring these people to talk the same language and go down to the counties, because they were mainly working to support counties in a lot of the things were, so we would develop a guidance, but then we take them down and support counties to implement some of those guidance, particularly in areas where they work. So what we saw is that we needed to bring them on board, listen to them, and just provide the leadership and the direction that was required for them to be able to deliver on their mandate. The other thing I mainly saw was that there was a lot of interest by the different partners to also give us the data from the ground upwards. So in that regard, we created a dashboard for the different partners, so that whatever they did in the field, they would bring it back to the committee on. We had very regular weekly meetings, standing meetings every Wednesday, and would present to the rest of the members. So people would feel very much appreciated when you presented that this is what this specific partner has been doing to support a specific county or a specific community to be able to do this COVID intervention to support the vulnerable members of communities, probably with the sanitation and hand washing facilities and so forth. And so we're able to really broadcast that information even in different Ministry of Health platforms, like in the Ministry of Health Twitter account, in the Facebook. And this really motivated the partners to continuously come back and work together with us. And the other thing is that a lot of them had actually diverted their resources from whatever it is they were being funded to do, and of course redirected those resources to do COVID work. So it was critical that also whoever funds them or their donor was able to actually see the value for that kind of redirection of resources to COVID-19. I think the other thing I would want to say is that what I saw was very useful was bringing on board other sectors. For example, we brought on board people with disabilities, because we soon realized that when we started giving the information to Kenyans about COVID-19, especially the briefings that were being done by the Ministry of Health leadership, we realized we didn't even have, for example, a simple thing like a sign language interpreter in those briefings, and then of course, and that meant that we were leaving out a large segment of the population who probably could not hear, maybe especially the deaf. So we were able to ensure that at every specific briefing, there was a sign language interpreter who was standing there, not just depending on of course, in mass, in the TVs and mainly, there's usually a sign language interpreter, but we made sure that in the physical briefing, there was also a sign language interpreter, so that anybody watching the briefing from anywhere would be able to understand what was going on. So I think I want to stop there and maybe give time to the other panelists to say something.
Thank you, Dr. Maureen. It's great to kind of hear that that feedback loop from the ground up and top down, kind of continuous, to make sure that I love the idea of the dashboard and updating it and engaging community as well as key partners. I think that's in the response effort. I want to invite Tim to chime in here. Tim, as a researcher, is at the forefront of generating some of this data and evidence. What do you see some of the ingredients for success in terms of taking data and evidence into policy and programs from your purview?
Thank you, Troy. I think three things are essential. One is, as a researcher, you need to think ahead and say, what am I generating this data for? And how is it going to be used? In what format is it going to be used? And what are the platforms that are necessary to be able to disseminate this data? And the COVID-19 context provided us with three things. First, a platform, an avenue, as Dr. Maureen mentioned, that we had this community engagement subcommittee that met every week to sort of deliberate on issues that are concerning this communication and engaging community towards preventive promotive measures. And number two, we then generated this evidence very quickly and rapidly, thanks to the existing cohort plus research assistants who are able to easily adapt to the context. Of course, there are challenges around that, quite a bit of, dealing with many issues around response rates and accessing these households and mothers to talk to. Again, we also had an opportunity to package this evidence in form of policy briefs and presentations. And these were very useful, small sets of information that could be used for implementation and use across various partners. As Maureen mentioned, we also supported the ministry to develop these partner maps, and on a weekly basis they could report on what they were doing, and we could present that, and they were very happy to use those dashboards very easily. I got emails and calls from people from various quarters saying, oh, you've not updated our map this week. We are able to do this and that. We are able to do that and that. So in the initial stages, those are some of the key ingredients that I think are useful. Being able to navigate the environment, being adaptable, being flexible to the context, and saying, what can you do to support both policymakers and stakeholders in the context of the pandemic like this? So I'll hand it over to you, Twai.
Thank you, Tim. That's great. I think being adaptive and thinking ahead is something that all of us researchers are being called upon to do throughout the pandemic, while maintain rigor and quality of data is very important as well. We supporting the response effort. I'd like to direct some of this question. The question is from the audience, but also kind of one question from me to George. George, I think it would be great to hear from your perspective is to kind of how do you build community awareness around COVID-19 through community health workers, but how do you also ensure access to essential health services like contraception and et cetera within the community through these community health workers, but also being aware that, the presence of community health workers in crowded environment like the informal settlements can also increase transmission risk of COVID-19. George, over to you.
Thank you, Thai. Yes, it is true that community sensitization is one of the strategic approaches that was defined by these different community engagement teams that were led by Dr. Maureen, that would quickly bring the majority of the population to understand the impact of COVID and how to counter COVID impact through response and containment approaches. And so we have a very strong relationship with communities through community partnerships that has been established through community health strategy in the country, which is led by Dr. Maureen. And she mobilized the sectors, different sectors on health, who are delivering services of community under her structure in terms of engaging them through a technical working groups on regular basis. And therefore, when the COVID outbreak or pandemic was announced, it found that there was already a foundation, as a functional foundation of community health system in Kenya. And this one found that partners are already working with communities. So it became not a difficult engagement with the lower end communities because the structures at the community level are functioning through community health workers and their supervisors. So we were able to engage the community structures to ensure that they mobilize households to understand the need to be aware of the danger of COVID response. And this was done through community health workers because each community health worker in Kenya is assigned a specific number of households based on the population coverage or geographical coverage where they are. Like in the informal settlements, they are covering, each community health worker could be covering between 100, 200 households. And that means they're able to work with these people and reach to them, and they know this household, and these people have accepted them. And so there is no much challenges in terms of access to these households. And again, when they were doing this, they were also utilized to be empowered through trainings using the developed guidelines by the team of Dr. Maureen on community engagement. We developed continued guidelines on services. Services should continue. And therefore, the community health workers or volunteers continue to sensitize the communities on the need to continue accessing the services. And these services were available through engagement with the existing health facilities that were providing static health services. Only the outreach services were halted or stopped because of the pandemic, but the facilities were able to provide services through regular referrals and through households visits that were community health workers were doing at the community level. And so that is how we managed to bring sensitization as a mechanism of impacting the response to COVID containment in the informal settlements of Kenya. Thank you.
Thank you very much, George. That's very enlightening, and it is so important that just to hear from your perspective on how you work within informal settlements to ensure that essential health services continue. Now, I continue to encourage the audience to send in your questions for the panelists if you have them. But I want to move to Karen and Julie. Just kind of, I think you both focus on adolescent and young people. I like to pull out some of the data point that Tim Tim mentioned, and it's something that is kind of on top of my mind as well as we think through how the pandemic takes shape. But, I think people are staying at home, adolescents are staying at home in crowded household. There's, risk for poor mental health, but also there's the gender disparity between access to technology for learning, as well as gender disparity in terms of food security and etc. So one is that how are you working together as researchers and policymakers to ensure that you are advocating for some of these services? And what's in place? What do you feel like needs to happen, or what's in place right now from the government of Kenya to tangibly address some of these concerns that we have with this very important generation of adolescents? They are the biggest cohort of adolescent and young people in history, and they are our future. So how do we ensure their health and well-being as we maneuver the pandemic? Karen, do you want to begin, and then Julie?
Sure. Tough question, Twy. Thank you. So I think that as we speak, I mean, it's not just in Kenya where there's a real struggle, I think, amongst policy in terms of immediate response to COVID prevention and sort of then the negative effects of the prevention measures. And I feel like adolescents are really in that bucket of suffering from the effects of the preventive measures. I do think in particular on mental health, there is an awareness. You hear the Ministry of Education talking about the need to provide psychosocial support to students as they come back to school. I think question remains on how they're going to do that, but at least I think they are aware of the mental health toll that it has taken on adolescents sort of being at home. And I think one of the things that is exciting to me about the project that Julie and I are working on is that there is an emphasis on hearing from adolescents what they see as some of the solutions. And so I really look forward to that piece of the work and weaving that into the roadmap that Julie is leading about sort of maybe the way out of COVID for adolescents, and really having it be a balance of some of this survey data and recommendations from the adolescents themselves.
Thanks, Karen. Thank you very much, Karen. I think that's great. And Julie, this is along with the question that I have, the audience would really like to hear a bit more about what is this roadmap that you all are talking about? Can you provide a bit more details on that as well?
Sure. I think the reality is, even pre-COVID and during, we recognize there's no one size fits approach, and that none allows for correct gender inequities or discriminating imbalances in society. So the roadmap we're talking about is, even as we've gone along with the study, what the current says, we've done the quantitative one, but we're going back in 2 weeks. We're starting the qualitative data collection, and this is across the country, across 8 sites, to ensure that we're reaching all regions in the country. The regions that disparities on education, we recognize that's more on the northern part of Kenya, and then you come into Nairobi. There's a lot of the economic discrimination that we are seeing a lot of. One thing that we've been clear is we're not going to preempt the data. So we sort of think, okay, this is what we're going to find, but already there are things about the data that has been really surprising to us. The mental health, like you mentioned, is higher than we expected it to be. The digital divide. So I think with each site, what works, going through each region and recognize, okay, this is working well in this part of the country. This is the set of interventions that seems to be working, and creating and developing roadmaps for that, so that we are actually being able to get to a place where we try to embody the spirit of leaving no one behind. So I think even among decision and policy makers, being able to present this data, being able to get to a place and creating a platform where investments in health, education, protection, and economic interventions, getting to a place where we are able to sit and connect and sort of. I think one of the things that is a strong point for the policy and strategy unit is the convening power we have. The office of the president gets to call, and the right people sit around the table and make the decisions and agree, disagree, and sort of chart a way forward collectively. So it's not necessarily just a Ministry of Health intervention or a Ministry of Education intervention, but a collective intervention that works and for adolescent girls. As Karen said, we have been, one of the things that is very critical in this process is being inclusive of adolescents. I often say that, we can't just leave young people as props to an event when we launch it and say, okay, we're talking about you having being part of the solutions. We held the adolescents, the validation meetings, I think a few weeks ago, just for them to resonate, to connect with the data. Does this resonate with you? What works for you? What do you see? And sort of hearing from them. I think also recognizing that what worked 10 years ago is not working now. A lot has evolved. the digital space has evolved so much. They have access to it, they're using it, it's a source of information. And how do we leverage in some of these things that are working for them so that we are able to speak a language that they understand and come up with a way forward that can be integrated well. And it's not something that we'll come up with reports or briefs that just sits somewhere on a shelf, but something that can be actually implemented well.
That's so poignant, Julie. I just love that. I think just pulling out a couple of key things that you said here is engaging with adolescents and really updated on knowledge, make sure that what we do, the data we generate, but also the intervention we generate resonate with them and have them be part of the solution. That's super great, and just really appreciate the Office of the President being able to convene scientists and other stakeholder looking at the multi-sectoral lens that the pandemic have had on all of us, and all of us to be able to update our knowledge and evidence. I think that's very important. I have one question here from the audience. I think it's specific to you, Dr. Marine. Is I think right now we are thinking about our frontline workers, and as we all know, I think all of us are experiencing some level of stress as the pandemic progress. But our frontline workers are more at risk. So how do we make sure that we protect our frontline health workers, particularly the community health worker from the Ministry of Health standpoint? Can you briefly talk to that effect, Dr. Marine?
Thank you, Christian. And maybe just to say that, as George has indicated earlier in his brief, is that community health workers at this point were very critical, especially in supporting contact tracing, of course, doing the initial sensitization of household members and so forth. So obviously we knew we have a wide range of community health workers. We have the very young, but we have a significant number of them who are elderly, over 50, 60 years. And of course, if we are talking about comorbidities, they are also likely to be suffering from those same comorbidities that are there. And then we also understand that for a large portion of our community health workers, they are just volunteers. Basically, they are not under any guaranteed monthly salary. Of course, they are not on any medical insurance cover and so forth. So at this point of the pandemic, it was critical for us to ensure that as much as we wanted them to support the efforts of the pandemic, that we were also very careful to ensure that their health and safety came first before anything else. And so one of the things we did as a ministry was to put together a document which we call Continuity of Community Health Services during the coronavirus pandemic. Of course, the community health work involves going from home to home. So they go to each household, educating the mothers or the whoever they find in the household about given or specific areas on health education and so forth. And this is usually very critical, especially in the hard to reach areas where access to health services is very difficult, in the urban informal settlements and so forth. So what we did was that we specified in our document that one, they were not supposed to, if they felt that maybe they were at risk because they had any of the maybe they were hypertensive or had diabetic or any other condition, they should not expose themselves. And so for those, we ensured that whoever works with them, whether it's the counties or the partners, that they did more phone communication with the household members who they needed to provide services for. And then the other thing is that we saw a lot of our partners and also the county were able to provide the personal protective equipment, particularly the surgical masks and the gloves to the community health workers, because either spread the infection to other households or become infected if they went to a household which had a COVID-19 patient. So that was very critical for us. And then the other thing is that at least during the pandemic, airtime, because a lot of times they were doing a lot of phone calls or SMS messages to the members of the household, which they serve, and of course the household members are also calling them in case they had any urgent health issue, which they required them to tell them where to go in terms of referral for services. So I'd want to say the other thing that has come out from me, and I think this has been recognized even at the legislative level, is the role that community health workers play. And so currently we have a bill, a community health services bill that is already in our national Senate, and this is seeking to ensure that community health workers are recognized and they can start to be paid or to be given a consistent remuneration just like any other health worker, and also that they are recognized at the county level so that all the leadership can recognize them. So that I think is something that has come out, that really at the leadership level, at the legislative level, they've recognized the importance of this cadre of workers, and there's a lot of effort towards ensuring that some legislation or is put across on the community health services, which will take care of all these other issues, the welfare issues for community health workers. Thank you.
Thank you, Dr. Marine. And I think that's just so great to hear the detailed plan that you have to support frontline health workers, and as a researchers, we also see our data collection effort on the ground at the frontline workers of the research chain value. So I think we are paying attention to that and also thinking about equity in that framework as well. Before we wrapped up today's webinar, I just want to bring forth some of what I heard as key points that is so important for all of us to take away. As I begin this webinar, I talk about the importance of investing in informal settlements and the disparity that exists within informal settlement as well. As we weather the pandemic, the pandemic will be with us for quite some time, and particularly without a biomedical intervention without a vaccine that will be available for until next year, probably well into next year. So I think it's important for us to ensure that we take a multi-sectoral lens in addressing the health inequity, but also the impact of COVID-19 within informal settlements, considering gender disparity, age disparity, income disparity, as well as prioritizing the needs of young people. They are our future, so thinking about them. And I really love this point around, bringing young people and adolescents to the table and hearing from them around what solution do they see, what is their lived experience throughout the pandemic, and really updating our knowledge on what works a decade ago, perhaps might not be working now during the pandemic time. So how do we make sure that research effort is grounded in reality? And I want to pick up this point that one of the panelists mentioned. I think advocates, we're really keen on raising issues that we're passionate about. But I think it's important for us to kind of be grounded in evidence, in data, when we bring this information to policymakers and investors, and just really think about how do we use data and evidence in our advocacy effort, but also in our response effort. And last but not least, my main takeaway from this great webinar is that I think often when you hear webinar on issue related to sub-Saharan Africa or Kenya, we often have experts from all over the globe talking about Kenya. But today we have people in the mix of it, at the front line, generating evidence, delivering services, formulate policy, revising policy based on data are coming in. So I think there is something really great to learn here is that the Ministry of Health and the Office of the President are really valuing the input across different partners, and they are really keen on bringing in these people, but also really using data and evidence to adapt their pandemic response, which is often neglected. And I think that is a critical issue as we move forward. Kenya is thinking about school openings, so how do we kind of handle some of the data around that? So I just want to, again, to kind of say, thank you all for your hard work in Kenya and for your presentation today. It's really important for us to gain insight in what you do. I also want to say thank you to the audience for your engaging question and for staying with us. And I want to thank the Population Council behind the scene team for putting together this webinar. As Karen and Tim mentioned, we've been doing COVID-19 related work across multiple contexts in numerous countries, working with the Ministry of Health, but COVID-19 task force in multiple countries. So you can visit our website to learn more and to find out the data and the evidence. But also you can sign up to atf@popcouncil.org to get our COVID-19 research digest. But without further ado, I just want to say once again, thank you panelists and thank you everybody for attending. It's been a very informative. Have a lovely day. Take care. Bye-bye.
Bye and bye-bye.